try to keep my lectures succinct. I'm Johnny, one of the PGY4s. I'm going to do a lecture on tracheostomy complications, how to recognize and manage them in the ED. So just going over quickly, the objective of my lecture is going to be try to review parts and anatomies of the tracheostomy, explore some of the common complications you'll see with tracheostomies, and then how to manage these ones. And then lastly, I really want to go over like resuscitation and airway management of patients with trachs and kind of go through like a structured algorithm. So, the scary things, we don't see them all too often, but these are things that we will have to deal with probably at some point in our careers. So just very quickly, usually over 100,000 tracheostomies are performed annually in the US here. Most of them, 40 to 50% of them will have pretty minor complications. But 1% will have catastrophic events, so we need to be prepared for them. Oftentimes you'll have a lot of airway deaths in the ICU or ED. Most of the time, they're going to be caused by like a dislodgement or like a decannulation event. So we should be very familiar with them as, that's one of our main things that we do. Um, so just to start by going over the parts of a trach. Um, so not all trachs are the same. There's many different types of them out there. Most of them nowadays will be kind of similar to the one you see on the screen here, where they're going to have a dual cannula kind of system. So you have this outer cannula, as well as a oftentimes replaceable inner cannula. The reason for this is that, in the respiratory system, there's a lot of gunk, a lot of mucus secretions. So we want to have something that we're easily able to replace or clean, or else like these will have so many more complications. Um, Other part that you'll see in trach is the last piece on the bottom here, the obturator. This you probably won't see with a patient who's coming in, but if we were to try to place a trach in the ED or like replace one, this is a useful tool. Now, what it does is it actually all it really does is just kind of blunts the edge, the end tip of the trach to prevent like injury to like the mucosa and things like that. So once the trach's already in, the obturator comes out. So you will probably won't see that. But if you were to try to replace one in the AED, it is important that you do use the obturator, as it will kind of prevent further injury. Common things that you're gonna know about trachs and you're gonna want to know about trachs is, in terms is whether it's gonna be cuffed or uncuffed, fenestrated, non-fenestrated. Just looking at it, the first thing you want to do is just kind of look for that pilot balloon. If there is a pilot balloon, you'll know that this trach is cuffed. And that's very important because, the cuff, it creates a seal. It means that no air gets past it, only goes through the trach. So that's something that you can identify very quickly and easily. The other piece that you'll see on a trach will be that faceplate, that flange. All right. Oftentimes you'll see numbers or markers on it. It will tell us the size of the trach. Oftentimes it'll tell us the diameter of the inner cannula, the outer cannula. Unfortunately, there is no uniform system of the information that's on it, depending on the company and the makers of each trach. But oftentimes you will, at the very least, see the size of the trach, usually like an 8 or 8.5. Yeah, and then you'll see sometimes like some letters like CN for like cuffed or like UN for uncuffed trachs. But again, they're all going to be different depending on the maker. And then another term, the fenestrated versus non-fenestrated, essentially means that if there's like a hole in it. The reason why this is important, for the same reason as the cuffed and uncuffed, is that if it's fenestrated and cuffed or uncuffed, it means the air can go past the trach, and meaning it'll go above the trach and will pass through the vocal cords. All right, so this allows patients to speak. So if you have a cuffed, non-fenestrated trach, the air is only going in and out through that trach, and they won't be able to make any vocalizations because there's no air going past the vocal cords. To review a little bit of the anatomy, so trachs are typically placed between the second, below the second tracheal ring. Usually it's done operatively. We can do emergency crikes, but our emergency crikes will place it higher up in order to kind of prevent any further injuries. So usually they're going to be kind of in the second ring trach. And then when we talk about the stoma and the maturity of it, it's going to be very dependent on time. So when we say if trach is, when we don't want to know if the trach is matured or immature stoma, less than 7 days or like 7 to 10 days, we consider that immature, and then greater than that, we consider that mature. Um, so overview of some common complications. So early, in early when we say like less than 1 week, um, we will see uh, expect like complications kind of involving bleeding, obstructions, false passages, and potentially like infections. And then when we talk about late complications, we're talking about like usually stenosis, tracheomalacias, fistulas, dislodgements. So I don't want to make it like a complicated lecture to go over all of these.
Johnny, your audio cut out just on from that last slide. I'm not sure if something happened.
Hello?
Good, I can hear you now.
Okay, we can all hear me now?
Yep,
Yeah.
sounds good.
So yeah, I guess I'll just restart. So patient comes in, post update 3. Tech was just cleaning him, noticed that trach popped out a little bit. She just pushed it back in. And then shortly after, noticing like respiratory stress and kind of difficult to ventilate. You could type in the chat, like, what do you think maybe happened? So, post update 3, this trach is very immature. They're coming out and getting placed back in while it sounds like very harmless. Yeah, false passage. While it may sound very harmless, to just kind of push it right back in, because of the immaturity of the stoma, it can very easily kind of go into the wrong place. Um, so we may see like from the outside, it looks like it's in the stoma, but on the inside, you may kind of be in like a subcutaneous tissue. Um, you know, this can be potentially very dangerous, because if you're ventilating and it's going into the subcutaneous tissue, you increase your risk of developing like a pneumomyostainium, pneumothorax, you get like this crunchy subcutaneous emphysema if you press on their skin. Um, so, if they're immature and they kind of be dislodged, we have to be very careful about them. If they're very stable, you want to get surgery and ENT involved immediately. But obviously, if they're not able to ventilate because of the dislodgement, we kind of have to do resuscitation, and I'll kind of talk about that a little bit later in the lecture. So moving on, just like a second case. Um, Patient, he's had this trach for years. He frequently just changes it on his own. But this time he took it out and then he wasn't able to put it back in. If you think about like what complication may cause this, yeah, like some sort of stenosis, right? So this is kind of more like a late complication findings. Oftentimes because either, if they're cuffed, if it is a cuff trach and it's overinflated, or if possibly the positioning of the trachs can cause like irritation to mucosa, and then even just over time, you can have stenosis of the passageway. Oftentimes it'll be either at the distal end of it, possibly sometimes it could be the stoma around the initial opening. Most of the time, it doesn't really cause any significant complications. If it's like less than 50% of the diameter, they oftentimes asymptomatic anyways. Um, but if these patients come in, because of the stenosis and you can't get it back in, you just go a size down and try to place something in. It's very important to try to place these in as soon as we can, because even for a long, like mature trach, um, it can narrow by like 50% within like the first 12 hours, and then within 24 hours it can even narrow by like 90%. So very important that we try to place these back in if there's any issues. So we'll move on to case 3. Patients coming from a nursing home after having a trach placed a couple weeks ago. Initially, they noticed a little bleeding. They tried to do a bit of suctioning. and then began bleeding profusely. Um, any ideas what was going on or what we could be concerned about? Yeah, an innominate fistula. So these don't happen quite as common as they used to since trachs we actually over time we actually started placing them a little bit higher up. But they can still occur pretty frequently. Um, they typically appear within the first 3 weeks of a trach placement, but peak incidence of them will usually be between day 7 and between 1 and 2 weeks, essentially. The way this occurs, you take a look at the anatomy. Oftentimes, it's either because of cuff or the distal tip of the trach is pressing against the anterior portion of the tracheal rings. Um, and then over time, it can kind of erode through and then could potentially rupture the innominate artery. And then it can cause like profuse bleeding. Um, so to manage these patients, what you want to do, you want to get ENT and surgery on board pretty much immediately. The same management is for any significant hemorrhage and blood loss. So you want to kind of like have MTP, reverse any kind of anticoagulation. Um, you can apply external compression over like the sternal notch, and then like so right above the notch, push posteriorly and see if you could try to compress and kind of occlude that bleed. Um, Also, what you want to do is you want to overinflate the cuff. So you want to inflate the cuff with like another 10 to 20 cc's, put more pressure on it, see if that could potentially occlude off the cuff. And if none of that works, what you can do is actually a digital compression of the innominate artery called the Utley maneuver. So what you would do is you would actually stick your finger into the stoma, um, going inferiorly and then try to compress and then pull your finger anteriorly and really try to compress that artery against the sternum. And you would actually hold this all the way until they get to the OR, and they will drape and sterilize everything around you in order to try to control that bleeding because arterial bleeds, they can bleed out and hemorrhage pretty quickly. Now the patients like trach to vents, brought in by family because his alarms are going off. We take a look at the monitor. You see this. Anybody notice anything on this monitor and see what may be causing the monitor to go off? If I could direct your attention to the bottom right corner, or on top, it actually writes it out. You'll see in like the bottom right, like the volume inspirations, like 382. Yeah. So, good job, Sagar. So this is a leak. So inspiration is you're getting 382, but expiration is you're getting out 280. So you're putting the machine's putting more air than it's getting back. So we suspect that there may be a leak somewhere. And then it could be from a couple of things. Right. It could either be like a leak because the cuff is not working, like there could be a rupture in the cuff, so you want to test that balloon to see if it's able to maintain its pressure. But something else that may be causing it is a fistula in the other direction. So if it was kind of anterior and went to like an artery, we're concerned for like bleeding and a innominate artery bleed. But if it were to potentially erode it through the back wall, through the posterior side, you may have a tracheoesophageal fistula, and then the air is kind of leaking out into the esophagus. You know, not very particularly dangerous. You're still able to ventilate them, but you may be distending the stomach. So if possible, if they have like a G tube or anything, you want to decompress the stomach to prevent any like risk of aspiration. But you do not want to be putting in like an NG tube from above because then you may potentially worsen it or even potentially drop it into the trachea. And then lastly, I want to talk about resuscitations. So I had a patient a couple weeks back, came in with a trach and was like hypoxic, not satting well, was in pretty respiratory distress. And as I say, I didn't feel the most comfortable taking care of these patients. But this is very well something that can happen to us, and we should have an algorithm to kind of go through. And going through it, it's really not that much different from how we would treat any any patient who is in acute respiratory distress, right? First thing you want to do, you assess that they're breathing on their own. If they are, you want to apply oxygen, right? So you see like this patient is hypoxic, but ventilating, breathing on their own. But you want to apply oxygen. So in this case, you want to apply oxygen to both the mouth and the stoma, because you don't know like where it's coming from, right? You want to be able to oxygenate both entryways into the lungs. All right. And then after that, if you play oxygen, they're still not sounding too well, they're still in kind of respiratory distress. The next step you want to do is you're going to remove that inner cannula and you want to try to suction. So this is going to be both diagnostic as well as therapeutic. If you try to push the suction through and it's goes through smoothly, it may there's no obstruction, it's fine. But if you're not able to get it through more than like a couple centimeters in, there's some sort of blockage, oftentimes a mucus plug. So a lot of times at this point, most of the trach complications are usually going to be like a mucus plug. So at this point, um, a lot of times it kind of solves from here. But say you can't get the suction through, you get it through like a centimeter two, but it gets some like obstruction. You don't want to force it. You don't want to force it through. So you're so this clearly means that there's some sort of blockage or obstruction of displacement. The next thing you want to do is actually, if there is a cuff on it, deflate the cuff and then see if you can maybe wiggle it about, adjust it a little bit, because it may be, just like slightly out of place, maybe against like the back wall, and maybe that's why you're not able to ventilate them well. So you try this step, deflate the cuff, reposition a little bit, and then you reassess them again. Are they improved or are they doing worse? All right. If they are not improving, okay, essentially at this point, the trache's not functional, right? So it's a scary thought to think about it, but if it's not functional, it's just in the way now, because now it's just some tube that's in your larynx, but you're not able to ventilate through it. So you want to remove it completely. Um, you know, Once you remove it, right, you still have to ventilate them, so you start bagging them, um, by usually by the mouth and as well as through the stoma. You do really want to do this simultaneously because again, you don't really know where they're able to ventilate and get through. Um, so for the mouth, same usual. You use your BVM. If you're going to ventilate the stoma, you could use like a pediatric cuff and then put it over the stoma, or you could use like an LMA and same thing. You just kind of put it over the stoma and you apply pressure. So say you do this and if they're doing better, you can continue to do this and you want to try to get a definitive airway. But if you're not able to ventilate them, then you definitely need to create some sort of airway because, same with your usual ABCs, if you're not able to get an airway, um, don't move the arm until you're able to. So in trach patients, to get a definitive airway, you're either going to orally intubate them from above, or you can replace the trach. At this point, it's going to be really important that you do know the maturity of the track for the same reason as I mentioned earlier. If this is a immature track, so if this is trach has been placed in like less than a week old, and you're trying to place it in blind, there's a very high likelihood that you may cause a false passage, and you're not doing the patient any good. So if you are going to attempt to reintubate through the stoma, you really want to do it using a laryngoscopy, where you can actually visualize the tract that you're going into before you place that trach. So otherwise, um, if it's immature, you pretty much always want to go oral. But if it was a mature track, you can actually go either way, which if you're comfortable, you can find a trach and then replace it through the stoma. All you do is just kind of line it up like parallel and then just rotate in. Um, so this is the full airway algorithm. So just to go over it, same as how we do. If they're, having difficulty ventilating, you want to give oxygen. Um, Most of the time, it's caused by like a plug or obstruction in the tube, so you want to you pass a suction catheter. It'll be both kind of diagnostic and potentially treat the problem if it's just like a mucus plug. If that doesn't work, you try to deflate the cuff, reposition of it. If that doesn't work, do not be afraid to remove the tube because you've done all your diagnostics, it's not working. Remove it, and then you have to place like a more definitive. Either you can ventilate them through a bag through the mouth and stoma, or you have to put like and then intubate them if you are unable to get a definitive airway. One last thing, just like a very special population. Some patients will have a very, very small population will have a laryngectomy. Um, in these cases, the larynx is no longer connected to the oropharynx. All right. So in these cases, if you're not able to get that from the history somehow, um, ventilating the mouth, bagging the mouth, really is not going to be any helpful at all because all you do is just pushing air into the stomach. In these patients, your only access is going to be through that stoma. So some key takeaways, you always want to know the maturity of the stoma. Do not hesitate to remove a non-functional trach. You want to prioritize oxygenation over diagnosis. Get ENT and anesthesia involved early and know your algorithm. So when they come in, you know what to do. The references. And anybody have any questions?